Today, we are going to be discussing esophageal manometry. So, without further ado, let's go ahead and get into it. First of all, conflicts of interest. I am a current clinical application specialist for Hamilton Medical. So, I do work for a ventilator company. So, let's go back a little bit. Let's have a little history lesson first. The first really instance of mechanical ventilation was from Claudius Galenus in 129 AD to 199 AD. It's when he lived. But he said if you take a dead animal, blow air through its larynx with a reed, you will fill its bronchi and watch the lungs attain the greatest distension. So this is really the first instance of mechanical ventilation, right? Now we're going to fast forward a few hundred years, and we're going to look at the first instance of CPR. So the first CPR was put into use by the Dutch, and it was a 5-step process. The first step was keep the patient warm. We tend not to do that anymore. We tend to go the other way with our CPR patients. Artificial respirations through the mouth. Yeah, we still do that, right? Stimulants placed orally. You can say we still do that, except it's intravenously now, and every once in a while down the endotracheal tube. Bleeding. We tend to avoid, excessive bleeding now, but back then when they thought that there were demons in people's blood, that seemed like a good idea. And then number 5, and this was actually considered the most important aspect of CPR, is fumigation with tobacco smoke through the rectum. So we know that's changed a little bit, but just imagine if they were still practicing like this today. You were working a night shift and just about to eat a nice sandwich. Coworker comes in the room. We got this code. I could really use your help. Can you grab the fumigation kit? So, as you can see, kind of how this conversation probably would have gone back then, right? And then you got this guy who definitely grabbed the wrong smokes. He was looking for his menthols. He didn't get it. But now we're going to come to the apex of respiratory technology. Okay. Let's look at our patient. 48-year-old female, almost 300 pounds, post-op small bowel resection and repair. History is coronary artery disease, anemia, DVT, abdominal pain, diabetes, hypoglycemia, all the stuff that normally comes along with this type of patient. Okay. Now, let's take a look at our x-ray. Say you're in the hospital, right? The medical team showed up and they have a similar reaction to smoking an ice cube, right? Not a lot of aeration going on there. Also, I want you to pay attention to her chest wall. Look how big that chest wall is. I mean, you can't even see where her chest wall ends on her right side. So, fairly large chest wall. Now, we start talking about esophageal manometry, we have to talk about the pleura, because essentially what you're doing with an esophageal pressure is you're getting a pleural pressure, and you're titrating your ventilator settings based on the pleural pressure readings that you get. So the pleura, you got 2 kinds: parietal, which lines the backside of the rib cage, and the visceral, which lines the outside of the lungs. All right, so let's talk about this. So holds 8 to 10 cc's of fluid total, so it's very, very small space. And it's mostly clear plasma from the chest wall capillaries. A little bit of solutes are in it: sodium, chloride, bicarbonate, right? There's a little glucose, albumin, macrophages, mesothelial cells, but it holds very little volume, okay? And this is important because that makes it very hard to get an actual pleural pressure measurement, which we'll talk about in a little bit. So the first instance of esophageal pressure was done in 1955 by Schirnack, and what he found was that changes in the pleural pressure were very similar to changes in esophageal pressure. And if you look at this CT scan of the esophagus, you'll find that it is completely surrounded by the parietal pleura. So when we're doing esophageal pressure measurement, we're getting a pleural pressure, but we're using the esophageal pressure as a proxy for actual pleural pressure. So we're not actually getting actual pleural pressure. We're kind of using the esophageal pressure as a surrogate for actual pleural pressure. Okay. So looking at your chest wall here. So this is a normal chest wall over here on the left. Over here on the right, you have a 550-pound patient. Now, if you notice, normal chest wall, not a lot of space between where the lungs end at the top and where the chest wall begins. There's also not a lot of distance between the end of the chest wall and the actual lungs. Whereas you look here at the 550-pound patient, there is a lot of mass in between on top of those lungs. And if you notice, the lungs are very, very collapsed because of that extra mass that's on top of them. So we know how much pressure we're delivering to the lungs at all times, right? We've got all kinds of pressure measurements on the ventilator: peak pressure, plateau pressure, PEEP, mean airway pressure. We have a whole myriad of options to look at ventilating pressures. What we don't know is how much force or how much pressure the chest wall and the pleural space is exerting on our lungs. And this is where esophageal pressure comes in. So let's look at our hierarchy of ventilating pressures. You got your peak pressure, plateau pressure, and transpulmonary pressure. Now, most common, definitely going to be your peak pressure. Is it also the easiest to obtain? Yeah, absolutely. All you got to do is look at the screen on any ventilator, and it'll tell you what the peak pressure is. Right there. You don't have to do anything. Just look at the screen. How important is it, though? Out of all the pressure measurements you can get on the ventilator, it's probably the least important. I know there's some people just clutching your pearls. Don't say that. I use that value. Well, you can use it, but compared to the other ventilatory pressure measurements, it is absolutely the least useful. And we'll talk about why. Next, we have the plateau pressure. Takes a little bit more effort to get, right? Now you got to hit a button. But is it more important than the peak pressure? Yeah, absolutely. We're getting more of a picture of what's going on inside our patient's chest than you would with peak pressure. And finally, you have transpulmonary pressure. Is it the hardest to do? Yes. It can take anywhere from 5 to 10 minutes to an hour to place that catheter, right? Definitely the most difficult to get. Definitely the least common. You're not going to do this on every single patient. You're going to do it on half of them. But as far as looking at your actual ventilatory pressures, this is hands down the most important measurement out of all of them. So when we look at what we're actually measuring with these pressures, this is how we find out exactly how important esophageal pressure is. So with peak pressure, you're getting your alveolar distending pressure, which we care about, right? That's really what we care about. Respiratory system pressures, which is essentially the force needed to move the chest wall, which we kind of don't care about. And then ventilator circuit pressures, which we really don't care about. I mean, that's not even inside the patient. So then we do a static hold, we get a plateau pressure. Now we've taken out the ventilator circuit pressures. Now we're left with just the respiratory system pressures, which we still don't care about, and the alveolar distending pressure, which we do care about. Finally, the transpulmonary pressure, we're able to weed out the respiratory system pressures, the pressures needed to move that chest wall, and now we're left with just alveolar distending pressure. So an esophageal balloon can actually tell you how much pressure is being applied directly to the alveoli. So let's look at the difference in pleural pressure and lung pressure. So say we're given our 5 centimeters of PEEP, our intrinsic PEEP. By the way, that comes from a study that was done in the 1950s on a bunch of healthy medical students. So of course, everybody's intrinsic PEEP was 5. Over the years, our population has grown significantly, not in number, but in girth. And I would say a good portion of our population has a much higher intrinsic PEEP than 5. Now, say our pleural pressure is 2. So what's going to happen? We're going to have lung expansion, maybe a little overdistension, right? So we're going to get bigger. Now, say, so 5 minus 2 equals a transpulmonary pressure of 3. And we'll get into what transpulmonary pressure is. But basically, a transpulmonary pressure is your airway pressure minus your esophageal pressure or your pleural pressure equals your transpulmonary pressure. So this person's transpulmonary pressure would be positive 3. Now, say our patient's chest wall now is 8 centimeters water pressure. So what's going to happen here? It's going to collapse the lungs, right? We have 5 minus 8 equals negative 3. So now this patient's transpulmonary pressure is negative 3. Ideally, you want your transpulmonary pressure to be between 0 and positive 2. If it's negative, you probably have lung collapse during exhalation. If it's above positive 2, you're probably overdistended. You can probably see that in your blood pressure, right? Say here, we got 23 and 8, and then 8 and 8. 23 minus 8, positive 15. And we'll talk about why this number becomes important later on. And now we have 8 centimeters water pressure in the alveolus and 8 centimeters water pressure in the pleural space. 8 minus 8 equals 0. So this patient's perfectly balanced. And it's kind of like Goldilocks with the bowls of porridge, right? In our first one, 5 minus 8 equals negative 3. It's definitely not enough PEEP that we are giving our patient. This patient needs more PEEP. As you can see, that chest wall is just collapsing that lung. Then we have overexpansion. 23 minus 8 equals positive 15. This patient has way too much PEEP. And you're probably seeing that in your blood pressure. Because fun fact, everybody thinks, you go up too high on your PEEP, your blood pressure tanks. How high is too high? Everybody's got some arbitrary number. 8, 10, 12. No. When PEEP goes above your patient's pleural pressure, that's when you have problems with blood pressure. Our body is built on balance. I mean, look at me. Right eye, right arm, left arm. I'm perfectly symmetrical. And all the pressures in my thorax are working in tandem with each other. Say you have a blood vessel and it's used to having 9 centimeters water pressure around it, and it's basing its vascular tone off of that external pressure coming from the lungs. Now the patient gets intubated. They're put on 5 of PEEP. Now you have a deficit of 4 centimeters water pressure. What happens to that blood vessel when all that pressure goes away? What happens to your blood pressure? Down. So you run into problems with blood pressure, not only when you exceed your patient's pleural pressure with PEEP, but also when you don't give enough PEEP. So a lot of the times actually going up on your PEEP is going to help improve your patient's hemodynamics. Okay? Rationale, what I've been talking about, is we're going to use the esophageal pressure as a surrogate for actual pleural pressure. Because we talked about that. The pleural space is very, very tiny. To get an actual transducer in there is going to take a surgical maneuver. It's going to be very hard to do. It's going to be very hard to maintain placement with that transducer. But if you put a balloon in the esophagus, it's really not going anywhere. It's much easier to do. You don't need a scalpel. You don't have to worry about bleeding, sterile procedure, none of that, right? So we're going to use an esophageal balloon as an actual kind of proxy for actual pleural pressure. Now, where does all this come from? Well, the first study was done in 2008 by Danny Talmer and Ray Ritz at Beth Israel up here in Boston near me. And what they found was that using the conventional protocol of PEEP management and then comparing that to titrating PEEP with esophageal pressure, the survivability of almost all patients went way, way, way up. So the survivability went up drastically based on the use of esophageal balloons and optimizing PEEP based on that. Now, there's a couple more pieces of literature I'm going to talk about later, but that is essentially the seminal piece. This is where all the talk of esophageal manometry really, really started, is with this paper. So first, we're going to talk about placing the balloon. This is the hardest part of the whole thing. Once you get the balloon placed, you're at the bedside for maybe 60 more seconds, titrating your ventilator pressures. But the placement, like I said before, take anywhere from 5 minutes all the way up to an hour. I've seen it even go past an hour with really difficult patients. But the data that you get is worth the time. So when it comes to insertion, there's 2 different types of catheters. A couple more are going to be coming out in the next year or 2. I know Hamilton Medical is trying to get a new one out. But you have the Cooper Surgical on the left-hand side and the Smart Cath by Vyaire on the right-hand side. Now, both of these will give you that, but the Cooper Surgical balloon is just a balloon, whereas the Smart Cath is a combination of esophageal balloon and a gastric tube, a feeding tube. It is easier to place because it's bigger, it's more rigid, but you do have to fight with nursing staff over the placement because sometimes the placement of the balloon does not jive with where nursing wants the placement in the belly. All right. You're going to go either oral or nasal for your placement. I find that people tend to have more luck going oral. It tends to just coil in the nasopharynx whenever I see people trying to go nasal. But I do have a couple customers who swear that nasal is the only way to do this. You're going to advance very gently. And you're going to do 1 to 2 centimeters at a time. So 1 to 2 centimeters, wait a second or 2, right? And then you're going to advance another couple. And the reason why is because as you're advancing, the balloon will start to coil maybe. If you stop advancing, peristalsis and gravity will naturally straighten that balloon out, right? So if you let it coil too much, though, then you have to pull it back until it's not coiled anymore and then try to re-advance it. Whereas if you just go kind of slowly and stop every few centimeters and just let it naturally straighten out, you'll find that it's much, much easier to place. Jaw thrust is also recommended. And also, you know, us respiratory therapists, we're used to having everybody in that sniffing position, right? It opens up the airway. Well, we're not trying to go in the airway this time, are we? We're trying to go in the esophagus. So, putting their head forward, a little chin to chest action. Not totally chin to chest, but definitely head forward. It's going to help you open up that esophagus and get that balloon down in there. So having a partner there to hold jaw thrust and lift that head up and lean it forward a little bit, it's definitely going to help your efforts in dropping this balloon. And you want to go down to 55, 60 centimeters. Basically, you want the balloon to end up in the stomach. And then you're going to do a stomach push. So stomach push is essentially you're going to do a expiratory hold. And then during the expiratory hold, you're going to press on the stomach a couple times. And what you should see is spikes in your esophageal pressure. And if you look here, PES is our esophageal pressure waveform. And you should see a couple spikes just like this, right? Now, why do we put it in the stomach? Because eventually we want it to sit behind the heart. So why do we all go all the way down to the stomach? Well, there's really no radio-opaque line. There's really no way to see an esophageal balloon on an X-ray, especially the Cooper Surgical. That thing, without the stylet in it, is the diameter and rigidity of a piece of angel hair pasta. Plus, there's so much other stuff in the airway and the esophagus. You just can't see it, okay? So, but we need to confirm that it's not in the lungs. So if we can confirm that the esophageal balloon is in the stomach, we're also confirming it's not in the lungs. So this is why we go all the way down. This is why we do our stomach push, just to confirm that it's not in the lungs. Now, once we have confirmed our stomach push, take that stylet out, and we're going to inflate our balloon. Okay. Generally, with the Cooper Surgical, you want to put 3 cc's in to fully inflate the balloon. That's because if it's coiled in the stomach, fully inflating it will pop it straight. And then you want to take 2 cc's out. So you want a working volume of 1 cc in that balloon. And you're going to pull out very slowly, and you're going to look for cardiac oscillations, right? And if you look down here, the bottom of the graphic, you're going to start to see cardiac oscillations. The closer you get to the heart, the more pronounced those cardiac oscillations are going to be. And this is how you know you're getting closer to the heart. Normal adults, 25 to 40 centimeters at the teeth is going to give you optimal placement. Around 40, I tend to start to do the occlusion method just to make sure I don't overshoot it, because especially with the Cooper Surgical, if you overshoot it and go past the heart, you can't re-advance. I mean, it's the rigidity of a piece of angel hair pasta once you take that stylet in. And you can't put a stylet back in once you've taken it out. So you'll have to take the whole balloon out, get a new one, start all over again. So I'm very paranoid about overshooting the heart. So I will generally start doing occlusion methods around the 40 centimeter and keep pulling it back until I get optimal placement. Okay. We recommend having your ventilator screen set up as such. So you want your airway pressure on the top, esophageal pressure second, transpulmonary pressure third, and then for the fourth field, it is recommended that you have the flow waveform up, because you're going to be doing a lot of inspiratory and expiratory holds. So you're going to need to make sure that you're at a zero flow state. And the reason why we recommend this layout is because it's your math on the screen. You can visualize your math, because remember what I said before, airway pressure minus esophageal pressure equals transpulmonary pressure. So there's your math right there. This minus this equals this. And if you're using a Hamilton, there will be your inspiratory transpulmonary pressure and your expiratory transpulmonary pressure listed right there. Although for the most accurate data, it is recommended you still do inspiratory and expiratory holds when actually titrating your ventilator settings. But these will give you kind of ballpark estimates on how your patient's doing both for inspiration and expiration. So I talked about the occlusion test before. What is the occlusion test? Essentially what you want to do is, there's 2 ways you can do this. First way is chest push. And this is what most people do. So when you think you're in the right space or in the right neighborhood for balloon placement, what you want to do is do an expiratory hold and then press on the chest, probably a quarter to a third of the amount of force that we use on an actual chest compression. Okay. And what you should get is you should get a spike in airway pressure, right? Because you're pressing on the chest, you're pressing on the lungs. If you're in the right spot, you should get a spike in esophageal pressure of roughly the same magnitude. Is it ever going to be the exact same magnitude? I've seen that twice in my life. But if you can get close, usually within about 5 centimeters of water pressure, you're in a good spot. And since airway pressure minus esophageal pressure equals transpulmonary pressure, if these two are spiking up at the same magnitude, what's going on with the transpulmonary pressure? Almost nothing. There should be very little change in your transpulmonary pressure. That lets you know that you are in fact in the right place. Now your balloon's too low. So if you look at our pressures here, 16.9, 15.2 for an esophageal, which gives us a difference of 1.7 centimeters of water pressure. This patient has a very perfectly placed esophageal balloon. Whereas when it's too low, you got 41 for an airway pressure, 30, and we're off by 10.9 centimeters water pressure. So this balloon is way, way, way too low, right? So you would need to pull this back until it looked a little bit more like this. So when you do that chest push, these two pressures spike up at pretty much the same pressure. Now, the second thing you can do is considered a little bit more accurate, but very rarely you're going to be able to do this because the patients that you're going to be placing balloons in tend to have a large diameter, have a large girth, right? But this is the chest squeeze. So hands underneath the patient's armpits, squeeze in for 1 second, and then let go. And this is also during an expiratory hold. And you'll get a pressure waveform like this. Since it's a prolonged squeeze, you get more of an actual pressure waveform instead of just a spike. But again, these two should be popping up in roughly the same magnitude. And if you look here, it's 18.6 minus 14.1, 4.5 is our difference. So we're within 5. And as you can see, there's not a whole lot going on here in this transpulmonary waveform, which means these are very, very similar in pressure, which is exactly what you want. Right? Here is another picture of one. So they did the chest squeeze here, right? And we have 27, negative 0.3. Now, it doesn't matter if the number is negative or positive. You just want to be within 5, positive or negative. So negative 0.3, this patient's in the right place. This balloon is absolutely in the right place, okay? So there's your esophageal, there's your airway. Nothing going on in your transpulmonary pressure, which is exactly what you want for optimal placement. Now that we got it placed, let's get our measurements, okay? All right, so the first thing you want to do is you want to do an expiratory hold, and your goal is to get your transpulmonary pressure between 0 and positive 2 centimeters water pressure. And looking at here, so we did our expiratory hold, okay? This looks like more of a driving pressure. But your total PEEP minus your esophageal pressure is going to give you your end expiratory transpulmonary pressure. So this one is saying 11.5, but 3 is what we're looking at here, positive 3. 20.9, 17.9, and then 3 is actually this patient. So this patient's a little bit over-peeped, right? Remember, above positive 2, you're over-peeped, right? So this patient would actually need to go down. And if you look at the waveform, see how the waveform is above the 0 line? You want the expiratory waveform with optimal PEEP on the transpulmonary waveform to be just kind of over top of the 0 line. The closer it is to the 0 line, better it is for the patient. But if you're like positive 1, positive 1.5, that's fine too. Very rarely will you ever see it exactly 0. All right, so there's your total expiratory pressure. There's your esophageal pressure. And there is your end expiratory transpulmonary pressure. So this patient is a little bit over-peeped, right? So let's look at this patient here. PEEP is 5. Pleural pressure is 19. And your end expiratory transpulmonary pressure is negative 14. So this patient is massively under-peeped. And if you look here, the line is way below the 0 line. Your transpulmonary waveform on exhalation is way below 0, which means every time this patient exhales, their lungs are collapsing. And then when they get the next breath, they're reinflated, collapsing, reinflated. And this kind of ventilation is what causes lung shearing and a lung trauma and eventual mortality. This kills patients, okay? So having their optimal PEEP is very, very important. So now we've gone up on our PEEP. right? Positive 19. Floor pressure is 17. And expiratory transpulmonary pressure is 1.6. And inspiratory transpulmonary pressure is positive 27. So our patient is now optimally PEEPed, but now we're going to kill him with excessive amounts of driving pressure, okay? And our static compliance is 20. So we'll talk about our inspiratory transpulmonary pressure in a bit, but basically above 10, you see a drastic increase in mortality. Above 18 or 19, it's pretty much 100% mortality. Everybody dies. So if this patient keeps ventilating with these kind of pressures, the inspiratory transpulmonary pressure, they will die. This will 100% kill them. All right, so let's talk about driving pressure. Now there's two types. There's respiratory system driving pressure, which you can get on any ventilator. It is simply plateau minus PEEP. And you want that number to always be less than 15 centimeters of water pressure. Above 15, mortality just skyrockets. And then for your transpulmonary driving pressure, you want that less than 10, okay? And what I tell people about driving pressure is you should treat it like oxygen in neonates. The less you can give, the better the patient is for it, okay? So where does this driving pressure come from? The first study that really focused on driving pressure and is considered the gold standard for ventilation now, for lung protective ventilation, is in fact this one from Dr. Amato. And what he found, you look here, this came out in 2015. You look here, he kept the PEEP static and he increased the driving pressure. Mortality skyrocketed. Then he increased the PEEP and also increased the peak pressure, keeping the driving pressure static. Mortality did not change, even though he increased from a peak pressure of about 22 up to about 32. And then he kept the peak pressure the same while increasing PEEP, thus lowering the overall driving pressure. Mortality shot down. Look how much it shot down, right? So most ARDS authorities, there's different conferences and there's different groups that put out ARDS ventilation recommendations. All of them have kicked out tidal volumes of 4 to 6 per kilo and replaced it with respiratory system driving pressure under 15. So it doesn't really matter how much tidal volume you're giving your patient. As long as their driving pressure is under 15, you're ventilating safely. If you're giving 18 cc's per kilo and their driving pressure is 11, safe. If you're giving 6 cc's per kilo of ideal body weight and the driving pressure is 19, you're ventilating unsafely. So it's all about driving pressure now, whereas it used to be focused on tidal volume. Now, I mean, if you give less volume, it's going to come out to giving less pressure too. So the ARDSNet wasn't totally wrong. They were on the right track. But Amato came along and just kind of honed it, sharpened it into what we should really be looking at, which is driving pressure. Okay? And looking at it here, right? Risk of death in the hospital, as driving pressure increases, it just skyrockets. Mortality just skyrockets. Okay? Then, a year later, Dr. Elias Cassis from Beth Israel came along and did the same study, but now he used esophageal balloons. And what he found was you really want to keep your respiratory system driving pressure, which remember, it's just plateau minus PEEP, below 14. Whereas Amato said less than 15. Even though this came out afterwards and includes esophageal balloons, Amato's is still considered the gold standard when it comes to looking at driving pressure. But he also looked at transpulmonary driving pressure. And what he found was that you want to keep your transpulmonary driving pressure below 10. And this is also the study that showed that above 18 or 19, it's 100% mortality. Like everybody dies. There's no survivors. And so this kind of solidified Amato's work the year before. So looking for air driving pressures, right? So right now we're doing a respiratory system driving pressure, plateau minus PEEP, right? So 31 minus 20, right? Or sorry, we don't have a PEEP number, but 31 minus 20 gives us 11.5 for a transpulmonary pressure. This patient is ventilating just a little bit unsafely, okay? So we got 31, 20, 11.5 for a transpulmonary driving pressure. So this patient, just a little bit unsafe. Now looking here, as far as air PEEP, you can tell this patient's under PEEP just by looking at the waveform, right? It's under the 0 line. You can tell this patient is got the perfect amount of PEEP because they are right above or right on that 0 line with their transpulmonary pressure, okay? And if you notice, this patient went from a PEEP of 12 to a PEEP of 15. Now, we're going to look at our driving pressure, right? So if you notice from the previous page, we're on a tidal volume of 450 cc's. Now, on a tidal volume of 400. And now, our inspiratory transpulmonary pressure, or transpulmonary driving pressure, is 9.1. So now this patient is being ventilated as safely as possible. They're on their optimal PEEP. They're being given a safe amount of alveolar distending pressure, right, which is 9 centimeters water pressure. And doesn't matter what the overall plateau is, as long as you're giving a driving pressure less than 10. I've seen patients on plateaus of 54, and their transpulmonary driving pressure was like 8, and everybody was happy. Ventilated safely, and you know what? These patients actually wound up getting extubated. They wound up walking out the hospital. So, again, as long as you're giving a safe driving pressure, your plateau pressure and your tidal volumes really don't matter, as long as that driving pressure is safe, okay? All right, so can't get away from this with me. Now we're going to use esophageal balloons to look at asynchronies. You can get the auto trigger, ineffective effort, delayed cycling, delayed inspiratory trigger, early cycling, and double trigger by looking at the esophageal waveform. And for what it's worth, getting an esophageal balloon into a spontaneous and awake patient is much easier than a passive patient. You just ask them to swallow, 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 and they just swallow it on down. Although you don't do the chest push anymore. Okay, that would be rude. Once you think you're in the right spot, you do an expiratory hold, and you watch the patient make efforts, right? The airway pressure will dip. If they're in the right place, the esophageal pressure will also dip at an equal magnitude, leaving you very little change in your transpulmonary pressure. And you also don't have to do a compression on someone who's awake. All right, so let's look at here. This is a auto trigger, which you can see right there. Now let's bring up the esophageal waveform. So as you can see, no patient effort is happening here. And by the way, these dips in your pleural pressure are spontaneous efforts, okay? Diaphragm contracts, creates a negative pressure. So this is that. As you can see, the patient was not making any effort when this little mini breath was given. So that would be your auto trigger. Next, we have an ineffective effort. The biggest way to notice this is really this bump and flow right here. There's also a dip in pressure, but I mean, with all that artifact, who can really pick that out? You'd have to be an absolute genius. But this bump and flow is pretty predominant. I mean, you can just eyeball that from outside the room. Now, if you notice, the patient did not make quite the amount of effort here that he did on, or she made on previous efforts. So that's probably why this patient had a missed effort. And then we've got early cycling, right? So if you look here, see this little bump in flow at the beginning of exhalation? As the patient's still making effort after the ventilator cycled into exhalation. If you notice, ventilator is cycling into exhalation right here, patient is still making effort. That's why you get that little bump and flow at the end. This would be an eye time issue, so you just increase your eye time, and this would go away. Synchronized patient, cycling into exhalation. Flow is also cycling, and the patient is pretty much ending their effort. So this would be the optimal way you would want your patient to ventilate. And then we've got the delayed cycle. This is what happens when the patient's done inspiring. They want to exhale, and the vent's not going to let them. You'll get this little spike in pressure at the end of your pressure waveform. I'm sure everybody's seen that. As your patient's trying to exhale, the ventilator's not letting them. You also get this steep drop in flow. And if you look here, patient has actually started to relax their diaphragm and they're trying to exhale, but the ventilator's just not letting them. So this would be less eye time. Over here on the left, we need more eye time. And then in the middle, perfectly synchronized. You don't need to do anything to that patient. All right, so now we've got our double trigger. I'm sure everybody's seen this. Everybody hates it. Everybody's got different names for it. Some people call it the bunny ears, cowboy hat, 10-gallon cowboy hat. Camel humps, double clutch. I've heard it all. But if you look here, what's happening is the ventilator's cycling into exhalation while the patient's in the middle of their effort. So that's why you get that immediate second breath. And if you also look at it from a lung protective standpoint, say you're given 6 per kilo, right? You're like, oh, I'm doing this lung protective thing, doing this RSNet thing. And you take a double trigger. They're not exhaling in between those 2 breaths. They're stacking. So now you're getting about 10 or 12 per kilo, which is not lung protective anymore. So actually the double trigger is actually very harmful and very dangerous for your patient. This can be fixed one of 2 ways, either by increasing your eye time or by giving more support. Say you have them dialed in for a tidal volume of 400 cc's. They want 500. That's where you get that second trigger from. So essentially, what's happening? Your patient is still making effort or in the middle of their effort when the ventilator cycles into exhalation. That's why you get those 2 breaths stacked right together with no exhalation in between. So this should actually be the patient's entire eye time. All right, so you got your delayed trigger. This little dip in pressure shows that patient's making effort, the ventilator's just not recognizing it. It's not ineffective effort because the ventilator eventually recognizes it and gives the breath, but it just takes a little while for it to be recognized. You can notice that by a little dip in pressure or slow rise in flow before this nice linear increase. And then down the esophageal waveform, look, pleural pressure starting to dip. The ventilator's not really doing a whole lot for it. And we're going to blow this up. And it's actually quite a long time for the ventilator actually recognizes your patient trying to make an effort. Okay? So ventilator's giving effort about here. Patient started their effort way back here. So this would be fixed by either making your ventilator more sensitive or going up on your PEEP. Because remember, if your patient has auto PEEP, they have to breathe through that auto PEEP and then through whatever trigger threshold you have set. So for easy math, say we're on a pressure trigger of -2. Patient has 4 centimeters water pressure of auto PEEP. That means to trigger the breath, they have to breathe through that 4 centimeters water pressure of auto PEEP, then the -2 that you have set on the ventilator, which means overall they have to generate 6 centimeters water pressure to trigger a breath. But on the ventilator, it just says they have to generate 2. The fix for that would be going up on the PEEP, help stint those airways open, right? Relieve some of that auto PEEP, let air move more freely back and forth because of the bigger lumen. So going up on PEEP will actually help with both ineffective efforts and delayed triggers. All right, so back to our patient. The rest of the medical team showed up. They all have very similar reactions to this lady's x-ray. Everybody's like, good gosh, there's not a whole lot of air going on in there. Okay. So, rate of 16, pressure control of 19, PEEP of 15, oxygen's 80%. Not looking too good. So, there's your pre-X-ray. And then 8 hours later, after we went up to a PEEP of 27, yeah, that's like, yeah, I said that, PEEP of 27. Look at those lungs now. Still, cannot even see where her chest wall ends on almost either side of the X-ray. So she definitely has a large amount of habitus, which means when she's not intubated, she's not walking around with PEEP 5. She's walking around with PEEP 27 that she's generating herself. So remember, when your patient gets intubated, take away all that intrinsic PEEP, and you have to give it back to them. So just remember, your bigger patients are not walking around with PEEP 5. They're walking around PEEP 10, 15, 20, even 27. Okay? And look at her oxygenation after all these PEEP increases. I mean, you can tell where the balloon hit. Boom, right here. Look at that. This is where they dropped the balloon. Look at that giant increase in oxygenation. All right, so summarize. Esophageal manometry. It's not on every ventilator, but the ones that have it should definitely utilize. There is literally no way that you can ventilate your patient any safer than with an esophageal balloon, both by setting optimal PEEP and maintaining a safe driving pressure. Safe driving pressure is just as important as the optimal PEEP. And also for your bigger patients, just remember, when it's time to extubate them, you know, if they had a, like this lady, needed PEEP 27, you should probably extubate her off PEEP 27, because if you try to do an SBT on her and turn her down to 5, just going to collapse those lungs and right back where you started. Remember, with someone with a large habitus, whatever you find out to be their optimal PEEP using an esophageal balloon, it's probably what they walk around with every day. So when it comes to extubating them, you should probably extubate them off of that pleural pressure measurement that you get with a balloon. I know it flies in the face of every piece of SBT literature ever, but it's true. All right. With that, I want to thank you for your attention and hope you guys have a wonderful day.